Okay. Good morning,
Yeah,
Dr.
good morning
Sal
and
and the
good evening
team.
here.
Yes, good evening there and good morning here. And I say that bye bye to COVID. I think we have to start with that, our life. And we all have been listening right from the morning with the case and so, and seeing it, and give the great opportunity to showcase from Mount Sinai, and with my team here. On left side, Dr. Anpurna Kini, Anu, and my fellow on the right side with Anup and Isha, and we are rest of the Cath Lab team. You can see the many of them very frequent visitor to our live series, knowing that we do 3 or 4 cases per month to India. And I know that this is a very educational session, which is done by SS organization, and we are happy to show you a case in a different way, different type, which is we don't talk too often, although we'll have a part of the discussion. And you can hear us and see us well.
Sure,
Yeah,
sir.
keep going.
We can hear
Oh,
you, and it's a great
Yes, yes,
pleasure
yes.
having you
beautiful.
here
Good.
again. And then it's all. I think it's going to be a good learning session. And Shamim Sharma, sir, you doesn't require any introduction here. You are so familiar with all this group here in our group, especially
Yes.
Indian cardiologists and even Kini there, and you were the
Yes.
entire team are very, very familiar. We have learned a lot of things from you. Not only now, for the last 20 years, we have been doing it. And it's
Yep.
great having you, sir. It's over to you. You can go to the case, sir.
All right, Dr. Salvamani, they're fantastic. And let's start with our first presentation. We get the, these are our disclosure actually, first slide. Yeah. This is SS Medical Trust and Abbott Vascular. Learn complex, making simple. And that will be our goal. This is the case number for you today because first case you already did. It's a 78-year-old male who has some CAD risk factor of hypertension, diabetes, even cholesterol was okay, and presented with new onset class 3 angina at outside hospital. And since it was first time, they did a stress MPI which was high risk positive for multivessel ischemia. They sent the patient to the emergency room. Troponin was negative, was transferred to Mount Sinai for further management. And of course, this patient was only on aspirin, Ramipril, and Glucophage, then added Metoprolol and isosorbide mononitrate, so 2 anti-ischemic therapy. And the cardiac cath done yesterday showed 2 vessel disease, and Anu will show it with the left dominant system with a normal ejection fraction and very calcific vessel.
So
Yeah,
this is the LV gram. EDP was
good.
normal.
Go to the
You
LV.
should.
Yeah, good. Yep.
Yeah. So here we are. Since it was a non-dominant right, we never took the picture of the right. So we have a guide picture. So distal left main is a large left main, not essentially involved, but you see significant calcific ostial LAD and significant calcific ostial circumflex, as well as a distal circ. So it's a dominant circ, you see distal circ disease also. So this is where we are. This is a caudal view, just AP caudal view, where you can see everything very well. LAD as well as circ has no disease further down.
So this basically by definition becomes 011. Although there is a little tapering of the distal left main, this is a 7 French guide, but large side left main, about 4.5 to 5 millimeter, and very tight lesion. So question is, a lot of people say, well, I want to decide based on the imaging what we need to do. But in our lab, this kind of case with such a tight lesion and very calcific, we'll just go with the treat it as a first hand and then do the imaging little later. And more important question will come that this 011, which still will be the part of the left main bifurcation, so this will be the case which were enrolled in the DK crush trials, that what to do strategy wise. So we felt make it a little different compared to what has been taught all the time, knowing that it's about 5 millimeter left main. And we go to the next slide. So that will be our goal today. So we said let's do a little different, and we supplemented with the bifurcate 3D. And so this our plan is calcium ostial left LAD actually and circumflex bifurcation using rota and V stent technique. V because main left main is completely fine. Ostium is completely fine. I know there is a lot of tendency to bring the stent up to the ostium, but ostial left main is completely normal because of that. So next. So this basically based on our OC criteria, it will make A, because high risk scan, diabetic patient, and started on double medical therapy. So that will be the goal. You want to show the at present or later?
We can,
Yeah.
as we're doing the case,
Yeah,
but I
yeah.
think here the discussion will be the same. The route, we are of course using femoral route for a complex procedure like this.
Go back to the fluoro.
LV function is normal, so even though it's a complex procedure, we should be able to do this case without any support. And then question comes is, we already mentioned angiographically is severe calcium.
Keep it close.
You see tram track without dye in both circumflex as LAD. Definitely LAD is worse than circumflex, so our goal will be that we'll do direct since it's a short lesion, we'll do direct rotational wire with a rotational athlectomy wire, and then it will be a floppy wire, and then we will do rotational athlectomy, followed by then we subsequently see how we proceed. So the plan will be, we'll do rotational athlectomy of the LAD, rotational athlectomy of the circumflex, and then we'll wire both the pre-dilate. We likely need a cutting balloon just to get full lesion preparation, and after that we will decide. We plan to do V-stent, we may change it to mini crush depending on how the vessel behaves.
Okay, so now Sal and the team there, let's have a discussion while we are wiring the LED. Give us your view and our other moderators and other faculties' view that how would they tackle this calcific lesion. We clearly know that you can always decide, try to do a high pressure balloon or a plaque modification, scoring or cutting balloon, and if don't open, then you may decide it. But we are very clear. So these kind of cases, the key is same. Complex makes simple. So just do the atherectomy. Rotational atherectomy will make this case simple by virtue of plaque modification.
Thank you, Dr. Sharma and Dr. Kinney. It's such a pleasure to be with you.
You are in the diagram.
Great learning journey. I just had a couple of questions. When you have a dominant system and both ostia involved, what about the hemodynamic support and the role of imaging? If you could speak on each one of them.
Okay, so LV function is normal, and like I mentioned, though it is left main and we know it's bifurcation, complexity wise, since EF is normal, EDP is normal, we think we still should be able to do this procedure without any hemodynamic support. But if somebody feels that they want to have hemodynamic support in this case, nothing wrong in considering hemodynamic support. Again, same, whether you want to use a balloon pump because EF is normal, or you want to go using impeller, both is acceptable. This guy's, I can just show you the picture of the groin. He has nice groin pictures here. Arteries are large.
Great.
Yeah, so that could be an option. All depends on the operator's comfort level, but we would not use that here unless
as you know, the part of the Protect 4 trial, which is ongoing, comparing our standard therapy in which include balloon pump with the Impella. So their entry point is EF of 40%. So patient has to have EF of less than 40% and then has a complex CAD, either left main or 3 vessel disease, or 2 complex lesions where more than 1 stent will be used. So this case, if the EF was less than 40, will become part of the Protect 4. We are the lead enroller in the trial, but still, by all definition, this case will not make it to any trial recommendation. Although many people, even in America, will they use the Impella. But I think the Impella will be overkill. If somebody wants to use balloon pump, I would have low resistance in this case, but definitely is not the case for Impella. So unless Girish or Sal, anybody, or Dr. Anand feel any different.
No, you are correct, sir, but it's a good LV function, stable patient. And when you are starting with the Rota directly, what size burr are you planning to take now?
So question was, you see the short lesion. So question was that do you go with the 1.75 or 2? We have 7 French guide. So we thought 1.75 combining with plaque modification, whether scoring balloon or some cases IVL. So IVL, one of the cost is the cost issue. So if let's say the your Wolverine and IVL is the same price. So I would say that all case just use a rotablation 1.75. I can tell you in last 8 months since we started using IVL, only 2 cases. We do about 60, 70 rota per month. The 2 cases we are done were 2 and above. So all 1.75. So do not go beyond 1.75. We'll keep our complications low. Then adjunct. Use a cutting balloon or IVL. I know IVL costs there in America also. It's very it's still same $4,500, close to 3 lakh rupees there. So these kind of cases, I would basically will do the rotablation 1.75. Do a cutting balloon. Lesion doesn't open. Then change it to the IVL.
Salim,
Yeah.
wire.
Okay, now we have Anu wanted to show.
Wire, start from the beginning.
Yeah. Okay, so they were going to show the app and we'll play the app side by side.
Not yet.
Right?
I don't know how to explain.
Yeah.
Okay. Tell us.
Hi, Dr. Samin. This is
Yeah.
Dr. Anand Rao.
Yes, Anand. Yeah.
Yeah. So you said this is going to be a V stent. That means you'll be having the dot of the marker of the balloon, whatever it is, in the left main, right? It is not
In the mid left main. Yeah. So we'll bring it to the mid left main. We'll not bring it to the ostium. Just to the mid left main. So question always comes that once you have it and patient comes back again, will it be a troublesome? I know that when we used to do our SKS, very troublesome in rewiring and advancing device. But we will be just like you're creating a two new ostia. So we'll bring circ and LED ostium like 2 millimeter inside or 3 millimeter inside in the left main. So it will be a new carina, new vessel. So that's one way. The V stenting we do very few now. SKS of course have been we haven't done in last 4 or 5 years now, but rare cases this could fit into the nice case of V stenting. Or if you want to make it a mini crush or DK crush, nothing wrong in that. So if we have to go with a crush, we'll use a mini crush technique in this case.
So I want to just go over how to wire.
Listen. Yeah. Sorry, you just say the question first, then we'll go to next. Yeah.
Yeah, my question is, if you do an imaging and if you find there is a plaque in the distal left main, will you still go ahead with the V stenting or will you convert this into a DK or a mini crush? Because to land both the barrels in a plaquey distal left main would be a concern.
Yeah.
Okay.
Understood.
Yeah, point well taken. That's why we say, I think I'll just go over some points, because there's always a question which wire to be used. So we do have this guide wire app. Also there's a website where we can decide. So this is a non-CTO. So when you go to non-CTO, and then we are going to decide this is a calcific lesion. Okay. So what's the kind of wire that you want to use? Here I know, because it was a short lesion, we just use rota wire directly. But if people want to think that they want to use something else, we would always pick what is a polymer jacketed wire in calcific lesion just to wire. So we or the wire, which usually we like fine cross the lesion, and then after that you change to rotafloppy. So 90% of the time we would go with the rotafloppy wire, and very rare cases, which are certain cases only, that we would say we would want to go with the extra support wire that we have. So this is just showing various fielder wires that are available. So all this is nicely described. We have a beautiful wire library. So this app can be downloaded and people can go and watch. There's a beautiful search function to understand all the wires, about over 130 coronary wires that have been described here. So coming back to this calcific lesion, we exactly like the question that you asked, that without doing imaging, how would you define what's the kind of treatment that you want to do? So this is a left main lesion that we have here. Why we cannot do imaging here? It's a 95% lesion. So I think we would not want to do any kind of imaging. So like Dr. Sharma mentioned, we will want to do angiographic definition here. So we will know it is severe calcium. And once we have defined severe calcium, which is just based on angiogram, definitely we choose atherectomy. And of course, we like rotational atherectomy the most. But if you decided to do imaging, you would want severe calcium, which is at least 3 quadrant of calcium that you will see on the OCT. And then we pick atherectomy. If you think it's a bifurcation, you always have to define, is there any disease in the side branch? So that is what we know, there is disease in the side branch here. And that's the time you decide what you want to do in the side branch. This is where we say how a complex case can be made simple, that we know we defined side branch, there is calcium, there's a lot of discussion, that people will be very uncomfortable that now you done root of the LAD, you want to take the wire out of the LAD and do rotational athlectomy of the side branch. There could be various discussion how you want to handle the side branch, but here we are going to show you that we can do safely the rotational athlectomy of the side branch. So that is the plan. That's how we are going to move, and now you can show what is V-stenting. We exactly accept your point that we will do atherectomy of both the branches, and maybe do balloon of both the branches, then we'll image, and then we will make a decision what's the stenting technique we want to do. Though we plan V-stenting, that's what we are going to show you right now on this video, which is a 3D bifurcate animation. But if we think we have to do mini crush, we will show mini crush. This is a web app. So this is V-stenting, what we plan to do.
Yep. And then the question came, because a large vessel, do you want to culotte? I mean, culotte is one technique, but I can tell you, again, you develop what you need to do in this, but we don't use a culotte. Unless there is already was a stent there and angulated side branch, could not be good for TAP. But culotte as a primary modality, we don't use in our cath lab. But yes, I know EBC1, left main bifurcation, they did talk about the culotte and so. But yes, culotte, a lot of people use it, but just a lot of metal in the culotte. So that usually we avoid. So this is the case of the V-stent technique, as we mentioned, that same. You want to bring it to the mid-left main, and that is the key. So bring both of them after lesion preparation. Both you inflate at 10 to 12, and then you do individual 16 atmosphere, while other one is deflated. So the idea there is that you expand the stent completely. 16 atmosphere is the cutoff, and after that you again 12 atmosphere, and then if ever required, you take them out, and then you bring 2 balloon and open proximally further, like optimization. So there, no need for any pot. Here, if you need to, you put that extra balloon within the stent boundary and go to high pressure with a 16 to 18 atmosphere. So this is where we are. So let's start the case now. Wire is already done. We have 1.75 bar. Go. Yeah. And there is a lot into this particular case. A lot of people will say want to protect the side branch and want to go with the putting the guide liner and then wire. No, not necessary. I can tell you, never needed. So once you are done, you can always just do a little balloon dilatation after rota.
The wire distal, yeah.
Okay, good. So wire goes a little distal, which is okay.
Any questions in the chat, or anybody wants any questions?
And a few of them which we saw, we have answered it, but any other specific questions which comes, we always, that's the purpose. We encourage our faculty, viewers, that ask the questions. Now this is the Rota Pro, which will be coming to India soon.
Sorry, what's the question?
What about the need for temporary pacemaker in this case?
Yeah, that's an excellent point. Dominant circ. If you want to use temporary pacemaker, that is a good choice. We did not, because patient, if it's elderly patient, we definitely would have. This guy is, we would say slightly older than middle age. So we did not decide. Is a dominant circ? Yes, very important. If you think you need it, we have a vein access, but we feel that likely we will not need a pacemaker.
Yeah.
So now we are leaving it in a left main, and do your 3 steps to remove. If you can show my fingers, you see here, you go backward, forward with the knob, where you are taking all the tension between the Teflon sheath and the bar. And next one is at the Y connector, you're moving the bar itself on the wire. So there are 3 things: the wire, the bar, the Teflon sheath. You have to make sure any tension between these strings are removed so that the bar doesn't not jump. And then we are on dyna, which you see here, the button is on. You see the light here. So on the dyna, we will just press a little bit. Yeah.
Nothing.
So dyna, is usually about 65,000-70,000 RPM. So even if it moves forward, it moves very slowly, gently. That way, you do not cause any issues of the rota. So we are all ready to start rotational athlectomy. If you can show, okay.
About
hemodynamics.
150,000 RPM, we have hemodynamics there. Yeah. Very short lesion. It went directly, so clearly, but you do bring back and change the wire position, and that will move the burr in a different direction. Yep. Good. So just, I know orbital has in the vertical axis, differential cutting here. You basically move the wire in different direction. That will make your burr more eccentrically, one way or other. More ablation. Now there are also,
Good, right?
yeah. So there are few papers about that. Do you just do a slow ablation, and that gets a better lumen on the OCT? There was one paper. Okay, we come back. Yeah, come back into the guide. Yeah, yeah. So now question comes is, can you put a wire into the circumflex? But first thing is you need to see your LED is okay. There's no issues with that. So we take a picture now. Looks all right. Good. Flora.
So I guess you can go to distal circ, so we can burr all the way.
So now usually it does not work, but since it's a very proximal lesion, we'll try.
Careful, careful.
No, I think we usually.
Yeah, go.
Just hold on. Let me get the clip closure. So many times to move the wire, it has to be on the Dynaglide. You take the brake release out on the Dynaglide, and then only your wire will be able to go advance. I mean, that exercise work not, we don't want to,
Go there, you're good.
We go to the OM?
Not OM, distal circ. Okay, let me see. Let me dissect.
Yeah.
Can I do it?
Yeah. Okay. Try.
Let me see.
Usually it's troublesome. I always have seen it's better to bring out and then go. Yeah, it is in that OM. We don't want that OM. You need to go distal.
You're in a small branch.
Yeah.
Okay.
I think we'll take less time.
No, 1 second. Let me just try without the
Okay.
rota clip. Yeah, otherwise we'll just take it out. Good. See?
Good.
So that was without the clip.
Yeah.
Connect the clip.
Good. All right. So we got that here. We go back again,
So
same
I
process.
just want to show the steps that what happens is when you have the rota wire, if people, you can see my hands here, yeah. So the rota wire is coming out here, but there's what's called as a brake. So this brake is holding the wire. So when you're doing rotational atherectomy, so the wire is not moving, the brake is holding the wire, and you need rotational atherectomy to be done. So if at any time you want to move the wire, or if you need to move the rota to a distal lesion, you need to do brake release. So to do brake release, you have to press here so you know you're releasing the brake, and then you move the wire. That's what we did.
Good. So now we restart our process for the circumflex.
Go forward.
Yeah.
No, go.
Yeah, good.
So again, I think we have to do the 3 steps. Just I'm going backward, forward,
Yeah.
Y
Too far.
connector,
Pull back a little bit.
and then we will do the dyna. Yeah.
Yep. Good. So we are okay. We start now, same 1.75 bar. We are putting into the circumflex now.
I need the fielder run through wire ready.
We have it ready. And here is the chance you could develop bradycardia asystole. So we should be ready with the atropine. And many times if required, you can always give aminoflin. So no need for pacemaker if you want to avoid it. Good. 20-second any given time. Now this one is a little troublesome, 1.75, because of the angulation. It doesn't appear that bad angulation this way, but it's clearly an angulation, but we'll try. This is only one time. Holding the guide, your hand on the left side on the guide, and gradually starting.
So packing motion, you see there, I'm going forward, pull back, going forward, pull back, and every time I'm going millimeter by millimeter forward. So it's a short lesion. Hopefully we'll go, yeah. You see that? So I cross the lesion, gentle movements.
Go to second also.
Okay, yeah.
Later.
So now, so there is lesion in the distal circ. So we plan to take the burr there. So we finished the proximal circ. Give some breathing time here. You see the hemodynamics so far stable.
And clearly the blood pressure should be always above 100. If you require, you give additional neosynephrine or so to increase. And yes, the question was whether there is a distal left main disease, but we expect there is a little distal left main. There is no question there here.
Okay,
See,
okay.
became bradycardic here. Yeah, good. Good.
Good.
Yeah.
Stay
Give
there.
atropine 0.5. Yeah. Give atropine now. Yep. Yeah. And flush.
Cough little
So
bit.
this is the
cough.
case. Yeah. Good. So clearly, as we said, as soon as the circumflex distally opened it with the atherectomy, and that patient developed this heart block, and fine, we are done. We are done. You want to do one more
I
polish?
want to try once more to go to the distal sac. If he shows bradycardia again, then I'm going to stop. I still want to try once more.
Thank you.
Give one of neo also.
I just had one more question. Would you image in this patient after rota, or do we go to the next step without imaging?
Okay.
Yeah.
I mean,
So let's go. So question will be
advance wire.
advance. Yeah, wire is good.
No, more. I want it more.
Good. Yeah. So question will be at what time you image. You know what? We are going to do a balloon dilatation, and then we decide. We are ready with the OCT.
Thank you.
Okay. Pull back.
Another question.
Go.
When you have osteal LAD, osteal circumflex, and if the guide is going to increase,
Stop.
What do you want? Huh?
Stop. I have to go forward.
Yeah.
would you
I'm sorry. What was the question?
Osteal-
do side holes to the guide?
No. In the osteal left main, yes. In osteal left main, yet, but not necessarily in the osteal LAD and osteal SARC. With osteal left main lesion, we always make a side hole in the guide catheter. Good. This is polishing nicely. Good.
So you see, when we gave some atropine,
Good. Yeah.
everything stabilized. But the question that was asked earlier, would a pacemaker should have been used? Yes, rightly so. If somebody wants to use it, was not wrong. Because of our experience, we knew how to handle it, and we showed it how to handle it. But to be safe, you want to do a pacemaker beforehand, nothing wrong with that.
Yeah. And particularly once you're doing a radial rotational athlectomy, even in the right corner, it become very troublesome. So what have been, we published back in 1998. There was a trial called BART, B-A-R-T. So what we did is, at that time, we gave a 1 milligram of atropine and 5 milligram per kilogram of aminophylline. So usually 300 milligram. So when you want to avoid pacemaker, you prophylactically treat the patient with a 300 milligram aminophylline and 1 milligram atropine before doing a rota, even if it is a right coronary. So in this particular case, we didn't feel that way. Now let's take a picture. We are balloon
as soon as now hemodynamics are good, but if you think there was any issue, risk of perforation, dissection, slow flow, that's why you need to do a picture. Everything looks okay here. I mean, if any of those things happened, you will immediately see EKG changes and hypotension. That's why we always, before you do, when you're doing rotational athlectomy, the fellows here who are at my side, they know they have the wire ready and we have a balloon ready just to take care of, and of course, vasodilators for slow flow if we need it.
Dr. Samin, what are your views? What are your views about the Japanese paper which was published? They say that you go do the first burr at 160 to 180,000 RPM, and then do the polishing with 100,000 RPM.
Yeah. So no, that is true. So I reviewed that paper before it was approved. But yeah, I think, again, to me, one, you want to go epicranial? Yeah. Let's go to epicranial. Yeah. So key is that what we have learned, that low speed, 150,000 RPM is quite good in terms of it causes less slow flow and less perforation. So this is what our earlier was. So actually Rota Pro, this device comes set with a 150. As soon as you go on, it is a 150,000 RPM. Now question is whether you have any different, there are a lot of issues which have been anecdotally. There was one paper with this OCT finding, and they did FDOCT, and so key was that some slow speed may give a better lumen, though that is one way. The other one which I mentioned, that change the wire position, so eccentric wire position many times, that also gives you to the better lumen. So this is where you direct indifference, so better ablation of the same bar. So there are few other things are there. So I would say I keep it simple, 150, and after your cross, you do a few times just polishing runs. So now we have put a run through wire in the LED, and we have the fielder wire into the circumflex. Now we can remove the rotor wire. We are going to dilate with a 3.25 cutting balloon.
And then we will do the imaging to see how the distal left main looks before we plan the stenting technique.
Yeah, but yeah, if the left main looks like the whole left main is diseased, then we have to bring it to the ostium. Then I think we'll just convert this into the mini crush. I know some people may say because a large vessel, little angulation, why not do the culotte? So that is another approved technique. I would say there's nothing wrong in that. But if we had to go different technique beyond the V here, we just go with the mini crush.
Yeah, what is the flush you are using for the OCT? That saline run, apparel. What do you use?
Yeah, for the rotablation. For the rotablation. For the rotablation, actually.
Exactly. Okay.
So rota we have it's a 5 milligram. Good. Yeah, I'm going up now. This is a 3.25. Yeah, it's a 3.25.
3.5.
There's no 3.5, but I know there is no 3.5.
The other one.
Yeah, it's a 3.25 Wolverine, because bigger sizes are not available nowadays. They don't make it. Yeah. Good. Just keep it there. Angiosculpt, and there is a new called Score Flex. We are getting that. Another with like angiosculpt technique, one balloon in the side. But this is the 3.25 few times. That's okay. Let's bring it back. Go to the ostium again. Now, flush wise, in a 1 liter bag, we put a 5 milligram heparin, 5 milligram nitro, and verapamil, and 5 milligram, 5,000 of heparin. Yeah, good. So this did okay. Let's cut ostium a little more. Yeah. So that is basically flush. Now, we also have the Rotaglide. Right? To pull back a little bit.
Very good.
The Rotaglide also, which is those who are not allergic to egg, we use. It's not available there, but Rotaglide actually we use many times to advance tough sheaths in the groin. So it's a emulsion, fatty emulsion, and idea there is just to decrease the heat generation. So that's where it is. So 5 milligram of the nitroglycerin, 5 milligram of verapamil, and 5,000 heparin 1 liter bag. Now, if the verapamil people don't want to use, which is okay, we can use Cardine. Those have been used, or Diltiazem has been used.
For the circ.
And now we are going to use the same cutting balloon for the circumflex, 3.25.
What is your take on doing left main to circumflex, large lumen, and then doing a tap for the LAD because of the angulation in the case?
No, but tap. To me, tap is remember tap, I want to say, if your main vessel stent was good and patient comes back, or you did a crossover and now you have to go to the side branch to cover, provisional, then you do a tap. Because tap as such, in the future, always give you trouble. Why? Because 1 or 2 strut always hanging in the main vessel. So if you can avoid it with a planned strategy, that's fine. I mean, same thing. That in this particular case, you want to use basically in the culotte, which is okay even.
Good.
So I would say that before going to tap in this particular case, I'll go with the culotte, if that is a concern.
Yeah.
So now it's the same 3.25.
Okay.
Wolverine, we are using it into the circumflex, both the areas, distal circ, and then we'll bring back to the proximal circ. And key is the same. How do you get a better mileage out of it? That you bring back into the guide, go back again, hopefully it'll cut in the different direction. And so, but as long as the balloon has been inflated, if not inflated, this is the time you intervene with IVL. Because you have done the atherectomy, you have done your plaque modification, go 2 millimeter in. Yeah, here, yeah, go up. Yeah, and if does not expand, then you use IVL.
Your preference of cutting balloon or scoring balloon?
No, I think clearly I saw that discussion about which one is better. I think from the ostial point of view, I mean, just think about the mechanism point of view. There are 3 blades or 4 blades compared to a wire around. So ostial definitely, I would say the cutting balloon gives you better lumen all the time. compared to the scoring balloon. But scoring balloon is very good to go to very high pressure, instant restenosis, unexpanded stent, and so. So right now we are good here. And now question is, do you want to do OCT going into the LAD in one of the vessels? Circumflex, okay. Okay, so I know the question was, yeah.
Wolverine, what pressure is this, sir?
Oh, Wolverine, you can easily go to 16 atmosphere. Compared to the old Flextome and cutting balloon, 10, 12 was maximum. Wolverine easily go to 16 and do not rupture. Of course, anything can rupture, but angiosculpt advantage is that you can go 20, 22 atmosphere. So Wolverine 16 atmosphere is absolutely fine, no problem here. So now Anu is doing that.
We're going with the OCT.
OCT into the circumflex. The purpose here is, I mean, this we are doing it clinically, we'll do it in the end, but since there was a question, but here we are trying to see what extent of the left main disease there. Silent. Angiographically, we know there is no disease in the, except just the distal left main, no disease, but is there any disease which is going to see it now? Now, and yeah.
Saline OCT, sir.
Huh?
Experience with?
Saline OCT.
Saline. Yeah.
We've never actually, we don't use that a lot. We do a lot of OCT here for research, actually.
So people are propagating there, but we are not being much more. But isn't that more saline for the right coronary? I know the people are using about, and there are some other agents they are looking into which are less nephrotoxic. But so far, no. So we had no experience of you doing the OCT with the saline.
You see it?
Yeah.
Yeah.
No, got it.
So can I check the paths again?
So this is the one thing about left main. If you really wanted to see left main, I have to have the guide. It's
Not the perfect.
not good?
Yeah. Okay. I think we can get.
Yeah, I know. They want the left main lesion. So
Yep.
let's see. Okay.
Yeah.
Yes. Yes. Good.
Okay.
And tell us your experience. I know there was discussion about the doing the OCT with the saline, that how it has been.
So I will do the co-registration first.
So as you rightly said, for the right coronary, saline is reasonably good. So, but for the left system, you need some extra device like mother and child, or you'll have to take a catheter right inside the LAD and then inject.
So from distal, this is distal normal circ. Come to the proximal. Yeah, this is a dissection after the loaded and the balloon. Go to the proximal. Yeah, this is a 2-quadrant calcium. That's a proximal circ. Go to more proximal. Yeah, both side calcium, like 3-quadrant calcium, like very thick calcium.
Very thick calcium still, huh?
Yeah, this is the plaque modification.
What is the depth of the calcium?
Wait,
I'll
let
check.
us see distal left main. Come
Okay.
to the
So
distal
go
left
to the
main.
proximal. So this is the nodule sticking inside, and come to more proximal. Yeah. So now I see that I think this is a LED from the 9 o'clock. Go to proximal. So this is a distal LED.
No disease.
So I'll change the depth. So I'm sorry. So,
No, hold on. Distal left main, no disease, right? Let's.
Okay. So yeah. So this is just a bifurcation. Left main
Right.
bifurcation.
That we know.
We don't see anything there.
Yeah. Come to proximal. Yeah. So almost nothing. Almost nothing. A little bit calcium nodule plug sticking into the inside. But the area is okay for
Okay,
the
so there's
distal
no
left main.
disease in the distal left main. So go back and give the thickness of the calcium.
Sure.
Yeah.
Depth.
So go to
Good.
distal.
Let's get the stents ready. Go.
So we go as
I
planned.
check
Yeah,
the
yeah.
4-0.
Yeah. Good.
yeah, like more than 1 millimeter. Yeah, very thick
No,
calcium.
that's good.
More than 3-quadrant.
4-0-23
Yeah.
and
I checked
3-5,
the
38.
distal.
38.
Yeah.
38.
Or 33.
The length should be 33 circumflex.
Yeah, I checked the distal EL to EL like 6, so I think 3.5 is good. And to the
So at least I mean just I would say that OCT reconfirmed what we had on angiogram. There is no disease in the left main beyond the distal segment. This is 4.
But
so Dr. Kinney, if we cover the after the OM
what?
part, it's gonna be a 38 millimeter, 36
38.
millimeter.
38, yeah. That's what angiographically we decided, 38.
Yeah.
And so we'll go to the circumflex stent, but
Leave it here. No, yeah.
If I may
yes. Yeah.
role for an IVL. You know, the proximal circumflex, when you look at it, it
Yes.
hasn't yielded well. There's no deep cut. Would you like
Yeah.
to see?
This is a deep cut after the loader in the balloon.
Yeah, good.
Good plaque modification.
Yeah.
His question is, do we consider IVL still?
Yeah. No, but I think
you know, based on our experience for all these years, this looks like after we did rotational atherectomy, one thing I would have changed is maybe we do not carry 3.5. This should have been a 3.5 flextome or Wolverine, sorry. We don't carry it because it's back order now. Should have been 3.5. If not, should have
4.0.
been at least a 4.0, because that's what we always say, that when you are doing calcific lesion, when you dilate, post dilate, maybe quarter size smaller with the Wolverine. But if you are using, has to be a NC balloon and 1-to-1 size high pressure, which we did not do here. That may be the reason you're seeing like that. But what we see that what rotational atherectomy has done, stent will expand well.
cut. It has cut the plaque. See the
Yeah,
multiple
see that?
places. Yeah.
Yeah.
But yes, coming back to the point, if the Wolverine had not expanded, then we put a IVL in there.
That's why we did the cine picture. I think that's where you can see right now it's fully expanded. If we see a dog bone effect, we know they did not expand, then we would go IVL. But if before IVL time, we will go with a higher, meaning a larger diameter balloon and higher pressure to expand it, and would not place a stent until we are happy that there is a full modification of the calcium at that level.
And that's a very good point, and we have incorporated in our algorithm, which I think I have shown it before. Can we go to the slide? So this is where you are right. I mean, IVL, if not the, go to just my slide, please, from the earlier one. So we just going to show, yeah. So just wanted to, that's a very important point, because whole purpose is the teaching, do the appropriate. So I think we probably had to go a little further. So 1 second, we'll go to this, our algorithm. We are trying to publish that, which clearly tomorrow also I'm in the CRT, have this session. Good. So this is basically is that you have moderate to severe calcium, and if you are very severely calcified, high calcium score points point of view, you go with the IVL. But clearly that you may require rotational atherectomy or orbital to get your delivery. Now, many cases are so uncrossable. We know that angulated lesion, IVL will not go. So you do a rotar OA, and then you do your NC balloon or cutting balloon, suboptimal balloon expansion, then you bring your IVL. So one, you can get IVL directly. But if it's a very circular calcium or very deep calcium, you may decide atherectomy or calcific nodule for that matter. But key is that once you are done already atherectomy, the best is that you are dilated with a balloon or cutting balloon, if not expanded full, then you go to lithotripsy before you putting a stent optimization. Yeah.
I think that was an interesting question that he raised, that we did atherectomy, and when is the one, I think everybody wants to know, we decide should we go with the IVL or no. Go back to that proximal circ OCT. Can we show that there? That Rota has done 9 cuts. Go a little bit proximal where you can see more. Yeah, look at that. Look at that. Come back. Yeah.
Yes.
Yeah.
Yeah, I think at this time we should not be going with the IVL.
Yeah.
Rotational atherectomy has done with cutting balloon, has done a good plaque modification. So we'll just proceed with the stenting. I hope that is clear.
Our plan. Good.
Yeah.
So now we are putting a 3.5.
Asking something.
Yeah.
Yes.
Sorry.
No. Thank you, sir. Sorry. Even the arc of calcium is also not more than 180 degree there.
Yeah. Good.
Yes. Yeah.
Okay. Go. So this is the 3.5, 38.
I would do mini crush.
Zion's sky point, huh?
Do mini crush. No.
No. We talked about we go, and we have 4.0. Yeah.
No,
Yeah.
would you like to take the LAD stent also now itself?
Right now. Yeah.
It's going right now.
Yep. Exactly.
And I think we have mentioned this in our app, always the side branch. Here the side branch we are considering as circ. I mean, if that's the case. Otherwise, if you think the side branch is more angulated, difficult, always go to the side branch first. So that we place the circumflex stent already. And now we are going with the LED stent. So with the circumflex, we have a 3538. With the LED, we are going with the 4023. Zion Sky
Good.
Point.
Okay. Zion's Sky Point. You hold it.
40 is a problem, I think.
Would you like to do a OCT in the LED also?
Pull back.
To look at the
I mean,
dilatation?
not now. We
Yeah.
know what we saw.
want-
Whatever we predicted in
Maybe
the
the end.
circumflex.
In the
yes,
end, maybe we can do that,
show
yeah.
it to you.
Good. Bring back the circumflex. We make a dot on the V. Both have to be
Can
overlapping.
we play the V stent animation
No,
side
they
by
did already.
side?
Yeah,
No,
side by
okay.
side. Yeah.
Right now. So we
Yeah,
see the
good.
dot.
Sine. Good. Right. Looks very good.
No, yeah, take the OCT out. Show the animation of the
Yep.
V stenting.
Play.
Start playing it. So this app is free, and we have a website called cardiologyapps.com. So all this various technique of stenting, bifurcation stenting technique, you can see all this animation. These animations can be downloaded and can be used for teaching purposes at any time. Good. So we are showing. So if you see here, go back.
Yep.
V stenting is, this is where exactly we are showing the two dots. And
Samin, what is
Yep.
the difference between this and simultaneous?
Oh, that's just 2 millimeter.
yeah, if was SKS, you will bring the carina, means you will have at least more than 2 millimeters. We are talking 3 to 4 millimeters extending into the left main. Okay.
Good.
So we're
Okay.
going up.
See
Going
that?
up with the circumflex first.
Yeah, both simultaneous. Go.
Go.
Oh. Move a little bit.
Yeah. Wait. Who is that?
What pressures we go simultaneously to
12 atmosphere.
I think
12 atmosphere. Both 12. Good.
LED stent seem to have moved.
Yeah. We are pulling back a little bit.
Yeah. Good.
No, wait.
Okay.
Okay,
Let's go.
good.
Yeah. Going up. 12 atmosphere both.
Pressure may go down.
This is the time. If you needed some hemodynamic support, this will be the one.
Okay, down.
Yeah, negative. Now, individually, we go 16 atmosphere. So we need to expand the stent. Okay. No, 1. Going first. 16. This is the Zion's Sky Point, which is not available there. I know the new generation stents will be, Zion's stents will be coming there too. And now this is again 16 atmosphere of the circ. Cine. Looks good, nicely expanded, negative. And now you go again, 12 atmosphere of both. And the proximal vessel is a 4 and 3.75, has to be about just 2/3, which will be about 5
After
millimeters.
this, we will do the OCT to before we think we need to post dilate.
Yeah.
If we need, then we will need short 8 millimeter balloon.
Of both of them,
Of
4 and 3.5. Yeah.
So you see that I will get the
Guide out.
guide right there and
Why
take
this is not
individually.
open? Is this open? Yeah. Yeah. Good.
Okay, let me take the balloon out.
And that is what always happens when these patients are quite a bit lying on the table. They get a little restless. Okay.
How high do you go on the stent balloon? 16, 18? Is that
Yeah. So basically, 12 simultaneous, then deflate, then individually go 16, just like we'll do any other stent. Deflate. Now you have expanded the individual stent. Now you go last again 12 atmosphere. So basically, because don't go too high, otherwise you call a proximal as dissection.
Oh man, see this?
The wire, there's always the issue with
Because
these.
if the stand,
yeah.
stand is out. No?
Yeah.
Because the guide was out.
Yeah,
to
guide
put
was
the
out, so
balloon.
why it pull the wire out. So put one wire into the LED at least. So we have one wire. Get the other wire. That's better.
This is a good learning to know that, we would not be going to the circ stent and then crossing into the LAD.
No. Yeah.
So it is always difficult
Yeah.
because there are two barrels. We don't know
Yep.
how it goes. Anyhow, let us see what happens.
Yeah. So it's very short. I mean, it's just basically like you had that carina at that time.
Now the guide is not
Yeah,
in.
your guide need to be in. So this is a little dilated aorta also in this particular case.
Guide may be too soft.
Yeah, guide has become, it was a VL. We use a VL guides. I know EBU and others. You want a new guide? Now we can have 6 French if you want.
Yeah.
Huh?
No, what if we need to post dilate with 4-0?
Yeah, 6 is fine. With the two
That was a
balloons.
4-0, right? 6 French 4-0.
VL 4-0. So yeah, what happened is the guide became very soft. Even first time, it was a little tough to manipulate. And we are going back now with the different.
No, don't put 6
Yeah, that's
French,
fine. Yeah, fine. Yeah.
I would not have put
I
the
think
guide out.
only
you
downside
took
of
it.
this
Sucked in.
simultaneous stenting is that second intervention. So
Yeah.
it's good we're learning that.
No, I would say that, 1 second. No, I would definitely not call the SKS because this is just at the ostium. You'll see by the OCT, will show it. It is just basically at the 2 millimeter from the ostium. So basically you have moved the carina. Just like there is a little carina in any particular case. Yeah, so, yeah, but you are right. I definitely, I was the basically inventor of the SKS. I would say in this day and age, there is no role unless you have like 6 millimeter proximal vessel and each side branch is 4. Maybe in that particular case, you want to go with the SKS and so. But we have now 5 millimeter and longer, larger stents and so no role. So clearly we only one case in last 5 years I had done. It was a 6-7 millimeter left main, the vein graft, which was going to the distal RCA and PDA. So there I had to put 4 stents in each. So that case I did a SKS. But otherwise, you want to nitro?
No.
Yeah, good.
Sir, if in this case, if there is a proximal dissection, how will you stent it?
No, but that definitely you'll make it as a there. Then you have to do a crush. Okay, which we don't expect, but yes.
Get a new fielder then.
Anytime when you have a proximal dissection, even in the V stenting, you have to turn it to the mini crush.
Run through wire. Run through.
We'll have to crush one of the branch and then recross it.
Then recross, yeah, exactly. So basically, will be little, yeah. So that will be a little bigger crush than what you usually do. We do a very small 1 or 2 millimeter crush. This will become a little bigger.
Get a fielder.
Good. Okay, here. So this is the wire right here. So we recrossing now. We are there and we'll show with the OCT that how overlap it is. And I can tell you overlap will be just 2 millimeter. And that is where the V stenting. Because yes, in the future to recross is always difficult.
Dr. Chini, would you want to fold the wire and send or just keep it on like a regular wire?
No, it's just a regular turn I have. Yeah, regular U curve that I have. Yeah.
So this is we want to go to circ, let it go to circ. So guide was a trouble even before because you're good.
Slightly shorter left.
Yeah. No, it's very now. Right now, it is the run through wire into the circumflex. Do you want to go into the LED also, or just do it?
Let's take a picture.
Okay, good.
So now your question was, how do we know where we are? You got that? You go cine.
Yeah.
This is what I would like to teach you guys. Sit down. Now this one is, don't inject.
Exactly.
Okay, go. So this definitely, you see that, looks like it's in the. So that's why I'm having a trouble in getting into the LED.
We can do
because
OCT
the
now.
guide is facing more into the circumflex.
Yeah. I think we can just do OCT and maybe done.
Okay.
Yeah.
They wanted to see the
Right? Yeah.
LED also.
No, but that's one place is
I have to see both.
Put another wire or just do OCT now?
Let me see into the LED.
So we are going to put a wire into the LED also. So then you want to OCT in the LED
Both
now,
ways.
right? We did a circ before.
No, we have to do both.
Both. Okay. So we need to do OCT in both the branches.
If the wire goes
Yeah.
easy.
So you're right. So many times what happen? If you have a loop, it is better.
But at the level of the left main, the loop will be harder.
Yeah.
Now what I'll do is I'll get the guide back, but when you bring it back, the guide is facing still. You may need FCL just to get into the FCL curve.
Maybe if you little more deep intubate, it may look up.
Yeah. That is correct. So only
But we
question.
have to be very careful. You will not have LSD of the stent.
Yeah.
That was the reason I pulled the guide out a little bit and
And
then
that came out.
everything came out.
Oh, now we have this connection. You want to do.
I told you. Not even that.
Okay. Ready?
Do you do post dilatation of the proximal parts of the stent?
I mean,
No,
since.
that's why our plan was we don't actually have to do it, but
Right.
Because we had done so much plaque modification. That's the key. Good.
no, this may be through the circumflex stent.
No, this is good. No. It's fine. Good. Okay. So let's do ready
Now
for.
this one I'm not clear if I might have gone through the circ stent and gone into the LED, but that's okay. We'll do the OCT of the circ first, okay?
Good.
Yes.
Good. Okay. We are ready.
And that actually can tell us how.
Or can we just occlude the circ ostium with the balloon and then.
If need to be. Yeah, that is true. Yes. So many cases when there is a trouble, you can always occlude the side branch with a balloon and then your wire will go into the other branch. But this will not be necessary, as I mentioned, it's just a very small overlap. And that was the goal. Just 2 millimeter. Don't go beyond 2 millimeter, just 2. Yeah.
Come closer. It could be also.
Good. Going in. Yep. We went into the.
Okay, stay there. Key.
Yeah.
Yes.
Going to inject.
You always take 55 or 75? What is the practice?
Sorry, what?
The length of the imaging, what do you do on a standard basis?
Yeah, 75.
Yes.
75.
Always.
Good.
Can you see it?
Yes, a bit.
Yeah?
Maybe we can try. Yeah.
Can't do more than that, okay?
Yeah.
No?
Sorry, not the good image.
No. Huh?
No clearance. I think you will have to reposition the guide.
Yeah, that's always the problem. And I know that is why a lot of people put up those additional catheter and then inject through it, more selective. And that become more for left main. So we'll try again.
You like to pull up
Good.
the guide, madam?
No, I did.
No, yeah.
I went in now. Hold
did.
on.
Yes.
Yes, we got the image.
Okay.
So I'll check.
Left main, the OCT is not the best imaging modality.
Yeah, for the proximal LED, left main is not perfect.
Okay,
Okay.
what do you
Let's
see?
see it now.
So just a moment.
Bring it.
I think we went to the LED.
Yeah. If we are done, we are
So
done.
I'll
We are
check from the
10 o'clock
distal.
past.
Okay. Yeah, maybe distal edge dissection.
Yeah,
And
but
come to
that's
proximal.
acceptable.
But stent is expanded. Go to proximal. Maybe die. So here now this is the So actually the proximal part is still residual blood. A lot of residual blood.
Yeah, you see very well. Proximal edge, there's no dissection, is well opposed.
Yeah.
Actually.
And what is the overlap segment? Can we see the double stent in that area?
Yeah, maybe still a little blood, but looks like this is a like double barrel. And come to proximal, like this part is a lot of blood.
So 1 millimeter, 2 millimeter, 5 millimeter, how much it is?
Less than 5, less than 5.
Okay, less than, I would say probably looks like 2 millimeter to me, same that our goal was. Good. So take a
Here
picture.
is the bifurcation.
Good.
Would you like to take one more image, keeping the lens marker very near the left main, just in the proximal circumflex, and do a just
or to the LED?
we can...
Or what about the LED? No?
So the left main, if you could just take the proximal circumflex and left main about 20 millimeter injection.
That should be fine. Yeah.
Yeah. Good. And do that. Answer
No,
what
why
the
we
question
cannot see the proximal circle? Show it to them.
Yeah, so I can see the proximal circ like this. Proximal circ is very expanded, well opposed. But if it come to the left main, like
yeah, but I don't think we'll be able to get a better image anymore.
Yeah, because guide is not perfect.
Can we get a better image or no?
No.
Then there's no need.
We should not push it anymore. I think we tried twice. This is the limitation.
Yeah.
We have to accept it. With that, we can see it, and angiographically, it looks very good.
Yeah.
For distal left main, you're really worried, then you have to change to angiographically. It looks good.
No,
right?
angiographic looks very good. Yeah. So question, let's do a last without the wire, which we always do. Come. And knowing that we got our full 1 hour. And yeah.
I'll take a picture with the.
Good.
Okay, take a nice picture.
Look at that. Fantastic. Our purpose was and really 2 millimeter overlap. So I clearly will say we do not plan and we did not do the SKS. Just a V stenting which we published is a 2 millimeter overlap, which is completely fine. That is what exactly happened without the wire. Yeah. So that is what exactly happened in this particular case. And very nice. No dissection. Proximal nice expansion. Can it be something else? Yes. Could have been mini crush. Could have been culotte. Could be DK crush. I would say probably not DK. I mean, it was a good case for mini crush and culotte. But we showed the different one, which is the V stenting, step by step, when necessary, and that is large because of the big left main. Left main being a 5.5. Yeah.
Heartwarming to see that there was no post dilatation and still there seems to be a very good apposition and area, probably because of plaque modification that was done prior.
Yes.
Okay. And I think the most important point we showed here is that when to do IVL and when not to do IVL, based on rotational athlectomy and Wolverine plaque modification, we showed that it was a good time that we proceed with the stenting rather than people think that maybe we should still consider based on the imaging that they still wanted to go to IVL. That probably is the most important learning part also here.
Okay, if okay
any
with
other questions on the chat?
Any other questions so we can answer because we went beyond our time. But I'm very happy that we had very educational, interactive discussion with our faculty as well as the participants who kept asking and pushing. I always, so this is the whole purpose of the format, that to teach. So any other questions left?
Sir, second time you could have taken a JL guide. That's what I think. One thing. And another thing, two operators, one after other, by increasing 2 millimeter, can it serve the purpose? What is the difference between the simultaneous as well as the one after other inflation?
Oh, you mean the V stenting versus SKS?
Yeah. So we basically, V stenting is as if there are two origin of the ostia. So usually, let's say it's the left main at this level. Here is just a 1 millimeter coverage. So a 2 millimeter. So key is that you are doing a minimal overlap. So anytime you go to next time, we'll go through it. So even let's say this patient develops significant lesion in the mid LAD, 5 year down the road calcific. Because just the true bifurcation, you have brought back 2 millimeter. So your rota bar can go through the V stenting. With SKS is troublesome, where it's a large barrel. You created a 2 barrel. Here just at the, and we showed by the OCT that it's less than 5 millimeter, about 2 millimeter, with they tell me precisely, 2 millimeter overlap. That's it. So key is that you are just creating like the 2 ostia. So if you go to in the proximal part of the left main, you'll see just the 2 ostia of the ostial circumflex and ostial LAD. So that's a big difference in SKS or V stenting. V stenting, think about your marker is at the level of the bifurcation. In SKS, it comes back into the main vessel, and then because of the barrel created, there is truly no barrel here. Barrel created can create a trouble in the future. Yeah, Anu, you want to say? Yeah.
I just had one last question.
Site.
For that new corona.
Yeah.
Sorry.
Yeah.
The new
Ask-
corona, would the tissue grow there over the period of time? Have you had any imaging experience on that?
Yeah, so that actually had been published even earlier in the SKS technique, even that carina, when patient comes back, do you see a shadow? You know, they call it a carinal diaphragm. It's a white shadow in SKS. In the V stenting, we never had a trouble because we never saw it. Because it's just one or two strut opposed. And so that is kind of many times happen in the cases of TAP. What do we do in the TAP? We do 1 or 2 millimeter projecting inside the main vessel. And so that also get endothelized. So this is the same situation, 1 or 2 millimeter of the main into the left main, it is projecting. So in terms of endothelization, so it's the same way when you do a tap, when your 1 millimeter of the strut is hanging into the main vessel. All right, Anu?
No,
Yeah,
I just
because we
wanted
need-
to show the slide because they had questions about this various technique. Go back to that. So this is the cardiologyapps.com. Are you showing the slide?
Yeah, slide again.
How much should be the left main length? If it is a short left main, can we do this V technique?
It's short left main. No. We are talking. We need above 6 millimeters, so you can do some two. Otherwise, you see the guide. You need to have enough guide to position it.
Yep.
So in a
Yep.
short left main, you won't be able to do it. In that situation,
There.
you would do probably mini crush technique. Yeah. So this is what I'm talking about. Is we have mobile application as well as cardiologyapps.com. When you go to cardiologyapps.com and put bifurcate 3D, you see key videos. You press the key videos, you start seeing all the techniques that we have described today. Whether you want mini crush, DK crush, culotte, V stenting, you can just go there, click it and see the animation, and you see side by side we are giving explanation how this procedure, what's the pressure of the stent, pressure of the balloon to be done. And if you go to the basics, we will also discuss predilation, wiring, type of wires that will to be used during this technique. So the key videos are the key. We can go and learn all this technique of various bifurcation stenting, whether it is left main or non-left main.
And it's an excellent, and they're true videos, true cases which have been compiled for this purpose. And I want to emphasize an end of this morning session, which has gone beyond some time, and I'll be going up and join you in your discussion. That what we did today is we did just a few millimeter overlap, and it did not come to the ostium. If you're thinking coming to the ostium left main, don't put your 2 stents. Trouble. Because subsequent engagement, because then your stent has to come out of the ostium. Anytime the guide will problem. Here we just have a 1 or 2 millimeter overlap at the level of bifurcation. So basically carina shifted 1 or 2 millimeters, so it should behave like any other stent overlap. And that endothelization, and so advancing your subsequent device will be no problem. And classical example was put a wire in the circumflex, and OCT went very well. I'm sure same thing for the LED. If you need to go to any device further, later on. So key is what we tried to illustrate today was the V stenting, and this was the ideal case because no ostial left main involved, and kind of just distal left main 011. So bringing 2 millimeter into the main vessel and having both 4 millimeter and 3.5 equivalent to about 5 point plus left main, 2/3 of the combined 7.5, which become 5.2. That was the left main, and has a nice apposition and demonstration of a little different. I know that everybody wants to just do a DK crush, maybe culotte or some mini crush, but we wanted to show a different live of the V stenting technique. But yes, somebody wants to change it to a culotte and a mini crush, there's nothing wrong in that. DK crush plus minus, but definitely because of large vessel both sizes, I would go with a mini crush or culotte if there will be the other alternate approach.
Excellent. And we learned a great thing. But to summarize what you said, if I'm correct, if it is 011, I think that's the case where we can try this V stenting and just keep the stent just at the bifurcation. And I think that point we have really learned, and probably selectively, few cases we can apply this in our routine practice. Thank you so much. Excellent demonstration. Very good explanation. We have learned a lot like any other previous sessions. Thank you very much, sir. Thank you very much for the entire team there.
Thank you. And I'll just see you shortly.